Morning, everyone. My sincere honor and pleasure to introduce today's special Grand Rounds topic on social justice and mental health. The presenter is Dr. Ruth Shim, who's an international expert in this area. I really appreciate Dr. Shim coming to present to our Grand Rounds today on one of the most high priority and challenging topics facing our society and our discipline. Thank you, Dr. Shim, for presenting today, and I'll pass it over to Lisa.
Thank you, Jeff. I'm also thrilled that Dr. Shim accepted our invitation to speak today. She and I met a couple of years ago when we convened a group of UC leaders in psychiatry within the diversity, equity, and inclusion space. And she took the lead writing a grant application about the mental health of underrepresented medical students. And more recently, we have collaborated, or as I like to think of it, conspired, as part of a national group of psychiatry heads of inclusive excellence in research, care, and education. This collective, which we refer to as FIERCE, recently submitted a manuscript about our joint experiences. So I can't wait to hear what Dr. Shim, a fierce advocate and talented scholar and clinician educator, has to say today. Appropriately, another fierce advocate and talented junior colleague, Dr. Alexandra Clark, will make the formal introduction. Dr. Clark is a graduate of the SDSU-UCSD Joint Doctoral Program in Clinical Psychology and currently a postdoctoral fellow in polytrauma and traumatic brain injury rehabilitation at VA San Diego. Take it away, Dr. Clark.
Thank you, Lisa. So I'm honored to have the privilege of introducing Dr. Shim as the speaker for our psychiatry department's diversity education and training special lecture this morning. She's a true leader in the field of cultural psychiatry with commitments to better understanding the social determinants of health disparities and improving mental health outcomes in minority patients. She received an MPH in health policy from Rollins School of Public Health at Emory University and an MD from Emory University School of Medicine. Dr. Shim's currently a Luke and Grace Kim Professor in Cultural Psychiatry at the Department of Psychiatry and Behavioral Sciences at UC Davis School of Medicine, as well as a Professor of Clinical Psychiatry, Director of Cultural Psychiatry, and Chair of the Vice Chancellor's Advisory Committee on Faculty Excellence and Diversity at UC Davis Health. Dr. Shim's also a member of the Board of Trustees of the Robert Wood Johnson Foundation, the American Association for Community Psychiatry, and the Research and Evaluation Committee of the California Mental Health Services Oversight and Accountability Commission. She's a 2018-2019 Fellow of the Executive Leadership in Academic Medicine Program and an at-large member of the National Academy of Sciences, Engineering, and Medicine Forum on Mental Health and Substance Use Disorders. Her impressive biography doesn't stop there, though, as Dr. Shim also serves on the editorial boards of Psychiatric Services and Community Mental Health Journal, and is a co-editor of the book, The Social Determinants of Mental Health, and the much-awaited upcoming book, Social Injustice and Mental Health, that will be published in early 2021. Finally, Dr. Shim provides clinical psychiatric care in the UC Davis Early Diagnosis and Preventative Treatment Clinic and has a record of research funding focused on addressing mental health disparities and inequities. While her commitments to diversity are certainly longstanding, Dr. Shim has also led the way in highlighting the negative effects of structural racism on psychiatry care and education, and has recently written candidly about her experience as a Black woman in organized psychiatry. I could certainly go on, but without further ado, we welcome Dr. Shim and the opportunity to learn more about the critical link between social justice and mental health.
Thank you so much, Dr. Clark, for that incredible introduction, and thank you, Dr. Eiler, and the rest of everyone in San Diego for inviting me. I'm just so pleased to be here. And I have a lot of content to go over, so I think we'll just launch right in, if that's okay with everyone. So I find that whenever I talk about issues related to social justice, social injustice, or structural racism, that I need to do a little bit of level setting. I need to do a little bit of disclosing and create some disclaimers. And therefore, I always like to do that. I found that times are changing. And as a result, I don't have to spend as much time on my disclaimers as I used to. I don't have to explain to people how difficult this topic is, how hard it is to talk about these concepts, how emotions are going to rise in you as we talk about these concepts, because somehow there's been a sea change recently that people are really starting to understand that. But that being said, it's still worth acknowledging that these are difficult topics and that emotions do bubble up to the surface whenever we try to tackle these difficult issues. And I think that the emotion that is probably the most significant for most people has to do with guilt. And because James Baldwin was so adept at capturing these types of sentiments and emotions, I just want to start with this quote by James Baldwin, who said, "I'm not interested in anybody's guilt. Guilt is a luxury that we can no longer afford. You didn't do it and I didn't do it either, but I am responsible for it because I am a man and a citizen of this country, and you are responsible for it for the very same reason." So that is all of the level setting that I'm going to do today. That's my whole disclaimer. And for the rest of the time that we have together, I'm going to spend a little bit of time kind of describing how we got to where we are, and making sure we're all on the same page in terms of definitions and key concepts. I'm going to spend some time on key concepts, but something I'm going to do a little bit differently than typically is I usually present a lot of data. I usually educate people on specific studies and examples of the things that we're talking about. And I kind of feel like we're a little bit beyond that. I feel like we do have a general understanding of the data that's available. And so I'm not going to spend as much time going over the data because I actually want to make sure that we have enough time to really start to talk about solutions and where we need to go. And then from there, I hope we're going to have a very rich discussion. So how exactly did we get here? And this unfortunately has to do with the founding of this country. And this is back to those challenging things that I mentioned we're going to have to talk about. But the founding of this country, this idea of this ideal of America, this idea of the American dream. And the American dream is really that beautiful concept that we all are kind of in this place together at the same starting line. And if we all just work hard enough, if we all just do, our very best, we all have the same opportunities and the same chance at success, and that anybody from the most humble beginnings can rise and become kind of the most powerful and most well-resourced person in this country. The only problem with the American dream, which is again a beautiful concept, is that it was really created and founded on a lie. And the lie was that we're all equal and that we all have the same opportunities. But the truth of the matter is, from the beginning of the founding of this country, there were certain populations, particularly white men, that were elevated above all other groups. And we can't shy away from that. We built our laws in our country around the concept that certain populations were worthy of those opportunities, worthy of those rights, worthy of laws and general affording of opportunities over everyone else in the population. And so if we don't kind of confront that, and if we don't think about how those laws and how that centering of certain populations has led us to where we are, we don't really get to the foundation of what we're talking about. So let's take a minute to define a couple of concepts. The first one is health disparities. And health disparities are differences in health status among different segments of the population. And that includes differences that may occur by gender, race, or ethnicity, education or income, disability, or where you live. And we talk about health disparities all the time. I think we all know that, and we can all think about and kind of identify certain disparities that exist in health and disparities that exist in mental health and substance use disorders. We have a very good concept of this. Health inequities, though, is a little bit different from this concept. Health inequities are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And so let's just kind of look at those two definitions for a minute. We have health disparities, which again is kind of the way that I was taught to look at differences in health statuses. health status among different populations. Health disparities really kind of centers the pathology, or centers the driving force of why you see differences in health in the individual. It kind of says that that person or that group of people is responsible for the difference. Whereas health inequities is saying that there are policies and practices that we have created in our society that create barriers to opportunity, and those lead to those differences in health. So it's not necessarily seated in the individual as much as it's created by the policies that we all support and the laws that we pass in our society. And let's just think about that for a minute, because I often ask people to think, so what are the most common health disparities that you know of, or what are the most common mental health disparities that you're aware of? And we could spend the whole talk kind of listing them off, right? I mean, I can think of many common racial and ethnic disparities, for instance, that African-American men are more likely to be diagnosed with schizophrenia than a mood disorder compared to white men. Or we can talk about how women are more likely to be diagnosed with depression than men are. Or we could talk about how indigenous populations have higher rates of alcohol use disorder than other groups. We could go on and on and on and on. Unfortunately, that's not what we're focusing on today, but we could go on and on. And the question becomes, are these differences the result of some sort of intrinsic cultural difference between this particular group, or all of these women compared to these men, or all African-American men compared to white men, or all indigenous people compared to non-indigenous people? And when you really start to kind of unpack this, we're really actually not talking about health disparities. We're actually talking about health inequities. We're talking about how we have created systemic, avoidable, and unjust social and economic policies and practices that have created barriers to opportunity for all of these populations that have led to differences in health outcomes. And so what I think is so interesting about that is that when we talk about these things, when we name these things, we actually don't use the right language. And what's interesting about that is in other countries, when they talk about differences in health and what's causing most of those differences in health, they use the term health inequities. But here in the United States, we refer to this term as health disparities. And I think that it gets back to that whole idea of how this country was founded, the way that we think about things, and the ways that we're not necessarily always ready to confront the driving forces behind why we have differences in outcomes in this country. And so one more major definition, it has to do with the concept of social justice. And on the surface, I think it's a very noble cause. It's been distorted and kind of politically misinterpreted. But John Rawls was initially talking about assuring the protection of equal access of liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. And I think that that is an ideal that we can all really highlight, and I don't think there's a lot of debate about why that is a concept that we should strive to achieve. The particular point about taking care of the least advantaged members of society is particularly important when we talk about mental health and when we talk about substance use disorders, because what we find in this particular population is as a result of a number of unjust policies and practices and social and economic policies, that people with serious mental illness and people with substance use disorders really do end up becoming the least advantaged members of our society. Okay, so this is a very busy conceptualization that I hope everybody can see that describes the social determinants of mental health. So Michael Compton and I, a couple years back, kind of created this conceptualization of what drives the social determinants of mental health, and then what leads to poor health outcomes. And in addition to poor mental health outcomes, what leads to mental health inequities. So it's a very busy slide, but I'm going to start at the very bottom, which is kind of the foundation, and we'll just work our way up. So at the very bottom, we have public policies and we have social norms, and they are really the foundation, the drivers of mental health inequities and poor mental health outcomes in this country. So actually all over the world, but we're focusing on the US today. So public policies are the laws that we create as a society, and social norms are our general ideas or beliefs about the value and the worth of certain people. And these two things kind of work together in this kind of synergistic way. How we feel about who is important and who is not important in society drives the laws that we pass and drives the policies that we create. And so if we decide that one group of people is a really important and special group of people, then we pass laws that protect those people. We pass laws that help those people do better in society. If we decide that one group of people are bad people and they don't particularly contribute very much to society, then we pass laws that actually punish those people or harm those people in certain ways. And it's a confluence of those things, actually, because the other thing that's interesting about this is that policies can actually drive how we feel about people, right? So if you have certain laws or if you have certain certain policies in place, they can actually change overall society's general feelings about certain groups. And I think a perfect example of this actually has to do with laws against gay marriage. And the fact that as you started to see those laws change in society, you started to see generally people become much more accepting of LGBTQ populations than in the past. So the laws actually changed much. And of course, I'm not saying that everything is great now, but the laws did in fact cause a change in our social norms and in our movement towards acceptance of certain populations. So those things kind of go synergistically together. And then they create the unfair and unjust distribution of opportunity, which is back to that concept of social justice we're talking about, or social injustice, really. So this unfair and unjust distribution of opportunity, which is created by our laws and our policies and our social norms, then leads, in fact, to the social determinants of mental health. And so you see in these 4 boxes, several different social determinants of mental health. It includes adverse childhood experiences, racism and discrimination, interaction with the criminal justice system, things that relate to income like education, employment, or poverty, things that relate to basic needs like homelessness, food insecurity, transportation, and access to healthcare. And then things that are really kind of directly related to our environment, like adverse features of the built environment, neighborhood disorder, pollution, exposure, and climate change. So all of those social determinants of mental health then lead to a host of risk factors. They can be behavioral risk factors or psychological risk factors, physiological stress responses, or they could be this change in behavior in which people who have poor options and don't have a lot of options or choices then in fact make what we determine to be poor choices. So we say that certain people are not making good decisions, but we are not necessarily pointing out that these determinants have driven limited options for people. A perfect example that I like to use for this is just the idea that we often talk about people eating healthy and making decisions about eating healthy food. And if you have a very limited income and you have maybe $1.50 a day to eat an entire meal, the question becomes, you go to the doctor and the doctor says, why are you eating fast food every day? Why are you eating hamburgers? You should be eating carrots. And the truth of the matter is you should be eating carrots. That's better for you. You should be eating fresh food. But if you only have $1.50 to spend in a day for food, it's actually a really good choice to choose a hamburger that's calorie dense, that's going to keep you filled for a longer period of time. It's going to keep you from feeling hunger. And it's going to sustain you better than a carrot or 2 carrots or however many carrots you can buy for $1.50. So in fact, what we look at as poor choices, why can't people take care of themselves? Why can't they eat a healthy diet? Actually becomes much more a result of our food policies, has much more to do with how much income people have and how much access they have to food. So all of those things then are the risk factors that lead to adverse mental health outcomes and also lead to unequitable or inequitable outcomes in mental health. And what I think is really interesting about this is that when I started thinking about and started doing research on the social determinants of mental health, I spent a lot of time talking about how if you're intervening at the level of the risk factor, you are too late, right? Because the illness has already been kind of set in and formed long before you get to the point of the risk factor. And so the idea was that you had to go further upstream. And so when we went further upstream, that's where we got to the social determinants of mental health. And we thought, oh, okay, here is where we need to intervene. And as time has gone by, I'm really starting to come to the understanding that even there is not upstream enough. Because the thing that's actually driving the social determinants of mental health and the social determinants of health are the unfair and the unjust distribution of policies and the laws and the ways that and the values that we have for people in society. And so if we're going to really go fully upstream to intervene on these things, we have to go all the way upstream. And that's at the level of addressing social justice and fixing social injustices if we want to improve mental health outcomes. Okay, so here are a couple of concepts that help us to just kind of understand how our frames are sometimes distorted and how we bring a certain level of bias to the way that we think about this. So when we're thinking about social injustice, one of the first things we need to think about is this concept of essentialism. And that is the belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization. It's this idea where you can take certain races and ethnicities and put them into different groups and say, this particular group does this particular group does that. It is how we get to an idea that we can kind of do analysis on the order of race, or we can do analysis based on ethnicity and come to clear understanding of differences of certain groups, when in fact those things do not exist, because there are not really these distinct categories, and things are constantly changing. The other concept that's really important is this idea of erasure of context. And that is when you fail to consider the socio-historical context when seeking to understand the etiology of inequities. And I think the best example of this is this concept of the protest psychosis, a great book written by Jonathan Metzl, where he describes how the subtitle of that book is How Schizophrenia Became a Black Disease. And it really describes how in the 60s, as the rise of the civil rights movement was coming to the fore, psychiatrists were actually redefining the concept of schizophrenia and turning schizophrenia from an illness that was actually previously seen mostly in white women who were rebelling against their housewife status and feeling like they wanted to do different things in their life than take care of their families, to an illness that was really about angry Black men who were protesting against the establishment and who were violent and aggressive and unreasonably paranoid about the established order. And so there's a beautiful article written about this called The Protest Psychosis, the original coining of this phrase. And if you look at it, it's kind of the case study of how you can erase context. Because all of the descriptions of the pathology of the young men that they were describing in this article, I think the article came out in 1967. All of the people that they were describing in this article, they described these behaviors without any context of what was happening as it relates to the civil rights movement. So if you have no context, you cannot really fully understand how these inequities came to be. And then another concept is biological determinism. This is the false belief that racial groups are biologically and genetically different. And it is really frustrating to me that in 2020, I have to list biological determinism and say it is the false belief that racial groups are biologically and genetically different, because the truth of the matter is we, particularly people in medicine, particularly people in mental health, we do not understand this concept. We actually, I think the majority of people believe that racial groups are in fact genetically different or biologically different. when all of the science and data we have does not support this. And a perfect example of this is this seminal study by Hoffman and others in 2016 that looked at medical students and asked them questions about pain. And medical students, a majority of medical students said that Black people feel less pain because they have less nerve endings and they have thicker skin. And so that was 2016. That was at a medical school. It's funny because there's so many ways to think about this, but I presented this data once to someone and they said, a very well-meaning colleague of mine said, okay, well, that particular medical school was in the South. And therefore, you know, like here in California, our medical students wouldn't think that. And I think that that is not accurate. I think that we all carry these beliefs and it doesn't really matter kind of where you are or who you are. If you've been raised in this culture, that's an understanding that people have. And then the last concept is cultural determinism, which is the false belief that differences in racial groups are the result of cultural factors. And so that is just a little twist on the biological determinism, that we can just as easily fall into this idea that cultures are so distinctly different that they're so different that they are the cause of differences in society. And so I often find, especially in my role as a cultural psychiatrist, that we often categorize groups by cultures, and often that those cultures are categorized by race or ethnicity. And there is an idea that certain cultural groups have misinformation, don't understand things in the same way, are just not as clearly well understood as other cultures. Okay, I have a couple more concepts. And one of them, I think another thing we can't not explore, that's like a double negative. Another thing we must explore, thank you. Another thing that we must explore is this concept of oppression. Because oppression is really at the heart of why we see health inequities and why we see mental health inequities. So when we said unjust social and economic policies and practices, what happens with those unjust policies and practices is that they lead to multiple different forms of oppression. And so those many forms of oppression take a lot of different roles. But I will just point out as we go through these, try to think about populations, certain populations, special populations, or vulnerable populations, or underserved populations, and see if you can categorize some of those populations or some of those groups into these categories of oppression, because really that is the driving force behind why we see these differences. So exploitation is the unequal exchange of one group's labor and energies for another group's advantage and advancement. And so it's the idea specifically, very clearly, that you're using somebody's labor and their energies, or you're misusing somebody's labor and energy. Cultural imperialism, which relates to this idea of cultural determinism, is establishing the ruling class culture as the norm and othering all groups that are not part of that dominant culture. And I'm going to have a very specific example of that for later in this talk. But just this idea that the ruling class culture is a frame where you don't question that norm, that is the norm, and there is no kind of analysis that needs to be done on that, and everything else is kind of pathological outside of that norm group. Powerlessness is the idea that oppressed groups lack power and are blocked from routes to gaining power. Marginalization is expelling specific groups from meaningful participation in society. And then violence, of course, which I think we all understand very clearly, are the threats and experiences of physical and structural violence. And when I say structural violence, I'm really talking about how certain groups can commit violence, either physical or harm, in any type of harm. It doesn't have to be violence, but when we're talking about structural violence, we're meaning a more powerful group committing harm against a less powerful. Getting a little note that my internet connection is unstable. So hopefully I stay with you all as I continue on and don't freeze. We'll see. I'll just keep my fingers crossed. Okay, so here is a pictorial of what we're trying to seek here, the ideal and what we're looking for. So the goal here is a combination, I think, of equity and justice. So inequality is, as it is when we have unequal access to opportunities. Equality, however, is this idea that everybody gets the same thing. Everybody gets the same intervention, whatever they need. So equality is when you evenly distribute tools and assistance. So as you can see here, everyone has the same ladder, the same tool to get to these apples. Of course, it's a problem for some people. And then equity, which is one of the goals, one of the things that we're trying to achieve. Equity is when you have custom tools that identify and address the inequality. And as you can see here, you've tailored the tools specifically to the group that needs them the most, and that leads to the better outcomes for that particular group. But as you can see, even with equity, it's still a little bit of a problem because it's harder to get to all of the various apples in that group. And finally, justice is fixing the system to offer equal access to both tools and opportunities. And as you can see here, it is idea of the system being the problem, that is where the intervention needs to be made. That the intervention is not about giving specific tools, that the intervention is really about making sure that everybody has that the intervention is made at the level of the system. Okay. Okay, so that was a bunch of definitions, and I think now we will focus on some key concepts. I hope everybody's still with me because I'm not seeing any.
Yep, you're good.
You're good.
Okay, great, thank you. I lost all video, so as long as you're still here. Okay, so there are multiple types of discrimination. And so there's legal and illegal discrimination. Legal, of course, being things like Jim Crow laws where the discrimination was baked into the policy. Illegal, of course, is kind of the way we think about discrimination, that there are many laws on the books that say you can't discriminate against certain people. And yet that discrimination happens anyway. So it can be legal or illegal. It can be overt or covert. Overt discrimination, you know, it's very clear what's happening. Covert discrimination is where it's that concept of microaggressions, where you're left kind of scratching your head and wondering, like, did that actually happen? And not being clear. And it's interesting because that covert discrimination does a whole lot of damage. Because you spend so much time and energy trying to like analyze and reanalyze and obsess over the interaction. And so those types of discrimination, the overt and particularly the covert, those are types of interpersonal or individual discrimination. So that's that discrimination that happens one-on-one, or it could be racism that happens between one group and another group. That is very different from institutional or organizational discrimination, which is much more similar to this idea of structural or systemic discrimination. So one particular organization, UCSD as an institution, for example, could be looked at in terms of how institutional discrimination takes place. And then structural is all of the structures in our society and those larger ways that we kind of look at systems in our society. What I will say about this is that when we talk about discrimination and when we talk about racism, much of the time we are overly focused on interpersonal discrimination and racism. We're very much about what is the one-on-one interaction that one person has with another person. And that's not insignificant, but for reasons that I will get into in just a second, it's not really where our focus should lie if we really want to affect change. So here are some groups that are commonly discriminated against in the United States. I have nothing else to say about this. The only other thing I would add is that this is not all of the groups that are commonly discriminated against. And when I say that these are groups that are commonly discriminated against, of course, we are talking about groups that are oppressed, groups that are marginalized, groups that are exploited, groups that do not have power. And so these are examples of lines by which those groups can have those experiences of oppression. Okay, and so now let's talk a little bit about structural racism, because I do think it's important to just really clearly hammer this concept home. So structural racism is a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. And it is a system that identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. And as you can see by this map, which shows redlining in this particular community, this is just one of the many ways that certain privileges were afforded to white people or people identified as white, and certain disadvantages were associated with people identified as people of color. And structural racism is not something that a few people or institutions choose to practice. Instead, it has been a feature of the social, economic, and political systems in which we all exist. And I think that's really critical because, again, I said we often revert to this idea of interpersonal discrimination and racism, and we think that it's one bad apple. We think that if we just fix this one person, this person is responsible for all of these problems. And in fact, that's not really the case. It's not one person, or it's not one evil villain as much as it is a feature of all of the systems that we live in and work in. And then the structural mechanisms do not require the actions or intentions of others, which is how we can all be really good people. We can all be well-meaning people, and we can still have the pernicious effects of structural racism in our society. And just to hammer that point home, even if we got rid of all of the interpersonal discrimination today, and there was never any more of that, we would still have racial and ethnic inequities, particularly in health and mental health, due to the persistence of structural racism. So because those structures are so built in and baked into the ways that we operate, the ways that we live as a society, it doesn't even matter if we were to stop harming each other on an individual level, because those systems are still in place. Okay, so a couple of examples about like how structural racism impacts health. And some of these examples I think are well known to people. Others are maybe not so well known. So the war on drugs, I actually feel, and I could be wrong, but I actually feel like most people have a very good concept of this. This idea that there were specific policies that were put in place, particularly with the intention to target certain populations, certain people of color, particularly Black and Latinx populations, that there were different policies created with different penalties. There was an idea that certain drugs were drugs that caused you to be a criminal and required you to go to jail, versus the ways that we think about the opioid epidemic right now, and the fact that we think of that much more as a public health crisis rather than thinking about it as criminal activity. So that led to a whole number of laws that we created in our society that were racist laws. Like, for instance, the sentencing disparity around cocaine versus crack, powder cocaine versus crack cocaine. And the idea that the same drug had a 100 to 1 difference in terms of sentencing. And that disparity has been really decreased over time, but given the fact that it's the same drug, it still seems very bizarre to me that we still have, I think, a 13 to 1 difference in substance use sentencing guidelines. So it's been reduced from 100 to 1 to 13 to 1, still clearly inequitable and still a policy that is structurally racist. Residential segregation, I feel again that people kind of know this concept, know that, you know, that redlining that was created led to highly segregated neighborhoods. But the other piece that's really important when we think about health is that those highly segregated neighborhoods then were divested in or invested in, depending on who you were and depending on what neighborhood you lived in. And so you can actually overlay with these residential segregation maps, with these redlining maps, you can overlay any number of other things, including poverty rates, food deserts, and I think most relevant to us, access to health clinics and access to mental health clinics. Because what happened is those neighborhoods that were deemed to be, you know, neighborhoods for people of color, those neighborhoods then did not, they were not invested in, and clinics were not built in those neighborhoods. And so people then had built-in access problems where they had to drive or go long distances in order to get to healthcare, among other things. Immigration policy is a very complicated example of structural racism, but I will just say that from the beginning of time, people have used immigration policies to craft very specifically who comes into this country and who does not. And what you find is that most of the people that enter the country are in fact immigrants that are particularly healthy. So as it relates to health and mental health, people have to be screened in order to be eligible to immigrate to this country. And if you have a psychotic condition, for example, you're not going to be eligible to come into this country as an immigrant. So what happens is the people that come into the country as immigrants are in fact the healthiest of that particular population. And so when you see this idea of this healthy immigrant effect, and the conclusions that people draw, or the erasure of context, would be to say, oh, that particular group of people, that particular population is just a healthier population. They just have better health outcomes. Maybe it's because of their cultural background, maybe it's because of the ways that they interact with people, but they're just a healthier group than the people in this country. So African Blacks or Caribbean Blacks are just healthier than Black people in the United States. And so if you don't have the context to understand that the only people that are allowed to immigrate to the United States are the healthiest of African Blacks and the healthiest of Caribbean Blacks, then you don't necessarily understand how these policies drive differences that we see and when we compare different groups. The Social Security Act of 1935 was a wonderful bill that created, out of the New Deal, created this idea of Social Security. And the issue was that older adults were not being able to retire or be financially stable when it came time for their retirement. So the idea of the Social Security Act was to create a retirement benefit for people. So once you had paid in and worked your whole life, by the time you became of retirement age, you could rest assured that the government would provide you with some type of financial support that you could then not be anxious and not be stressed about your final years and live out your retirement in comfort. The other nice thing about the Social Security Act is it not only allowed older adults not to be so stressed and anxious and financially burdened, but it also allowed them to start to build a little bit of wealth and pass that wealth on to their children and to other generations. So it's a great act. It did a lot of really great work, and it's on this list of structural racism. And the reason that it's on this list is because when the bill was passed in 1935, in order to get it passed as a law, there had to be a deal that was struck with the Southern senators. And that deal was that this bill would exclude domestic and agricultural workers. And so it just so happened that the domestic and agricultural workers at the time were mostly Black and Latinx people, particularly in the South, Black people. And then what ended up happening is that they were in fact excluded from this act. So they did not, after working their whole lives, get to retire and have this wonderful benefit, get to not live in financial insecurity. They did not get to pass their wealth on to other generations. And you see this wealth gap really expanded significantly. And that wealth gap also became a health gap that expanded significantly as a result of this Social Security Act and the way that it was passed. And finally, mental health care, we're going to spend a little bit of time kind of deep diving on that right now. So in 2018, 69% of Black adults with any mental illness received no treatment, and 42% of Black adults with serious mental illness received no treatment. So, you know, what we're saying here is that the majority of Black people, Black adults that had a mental health problem in 2018 did not receive treatment for that mental health problem. And it's the same with Latinx adults, almost exactly the same. In fact, 67% of Latinx adults with any mental illness received no treatment, and almost half of those Latinx adults with serious mental illness received no treatment. And finally, as it relates to substance use disorders, it's much more stark and much more disturbing, which is that 89% of Latinx adults with substance use disorders reported receiving no treatment, and 88% of Black adults with substance use disorders reported receiving no treatment. So what's interesting about this data is, you've heard these types of data presented before, and then we start to think about like what's driving this difference. And we unfortunately think about it through this lens in which we don't provide the right context to thinking about this question. So I've heard the number of reasons, and they are cultural determinist, biological determinist, culturally imperialist explanations for why this number of Black and Latinx adults are not accessing services, are not getting treatment even when they have these services. For example, there's higher rates of stigma in these populations, right? That Black adults and Latinx adults just have much more stigma as it relates to mental health, have much more stigma as it relates to substance use disorders, and they're not accessing treatment. Another example of a kind of a cultural determinist response would be, like Black adults and Latinx adults maybe don't have a lot of insight into the fact that they have a mental health problem and the fact that they have a substance use problem. So maybe they're not accessing services because they don't realize that they could get help, or they don't know. And I feel a little bit foolish kind of giving these examples because it sounds kind of ridiculous to me, but I have to say that these are common things that get brought up pretty regularly. But really, when we start to look at what is driving these things, cost is the most commonly reason cited among African Americans in particular for why they did not seek care. In this particular study by Along, it was twice as often as minimizing their symptoms, and it was nearly 5 times as often as stigma. So we often think that these issues are cultural, are internal, are kind of at the seat of the individual, that they are just not really understanding that they need to get help, that they have these stigmas and beliefs. But it really came down to not being able to access mental health services because they couldn't afford it, because we don't have insurance and we don't have a mental health system that appropriately allows everyone to access mental health services in this country. And when you look at the fact that we don't have a healthcare system in this country, outside of mental health, that we don't have a healthcare in this system, healthcare system in this country that allows everybody to access insurance. And then that we have disparities and we have a lack of parity in our mental health system. Again, those are laws and policies that we have created as a society based on who we've decided are worth value, who we've decided are people who deserve things, and who we've decided are not. And for more information on this, actually, I'll talk about it a little bit later, another resource for this. Okay, so Here is a graph of a CDC graph looking at COVID. And this is just a little bit of a case example of how even in the most kind of well-meaning, informed people, how you can default to some of those ways of thinking that we described are a little bit problematic. So this is an infographic that looks at COVID-19 cases, hospitalizations, and death by race and ethnicity. You can see that certain groups have higher rates of cases of hospitalization and death compared to white people. And I find that there are many problematic things about this particular infographic. First of all, we talked about this idea of cultural imperialism and the idea of norming things to the dominant culture. And this entire infographic is normed to white people. So you can see that they don't present any of the rates as it relates to white people. It just says what's higher or not higher as it compares to white people. And it is that centering of the normal group that is problematic in the ways that we kind of naturally just do this without even thinking. And then the other thing that I think is particularly disturbing about this particular infographic is this idea that at the very top of the infographic, they talk about the factors that increase community spread and individual risk. And they talk about crowded situations and close physical contact and enclosed space and duration of exposure. And most of those things are described, as behaviors and decisions that people are making that they can have some sort of control or some sort of power over. And it doesn't really get to the point until the very bottom of the infographic where it starts to mention that there are these risk markers like socioeconomic status, access to healthcare, and increased exposure to the virus due to occupation. So this idea of being a frontline and an essential worker. So all of those things at the top are individual behaviors that are very much driven by systemic and structural situations. And there's not really an acknowledgement of that until the very end, and it's a very minor acknowledgement. So this is just an example of kind of how we often think about things. We often, again, especially in the United States, we kind of move into this concept of thinking about the individual and thinking about the individual's decisions as the problem rather than the systems and the structures that create those problems. Okay, so in the last few minutes, I'm going to spend some time talking about where we need to go, and then I hope that will lead to us having a discussion as a group about what we can do about this stuff. Okay, so I showed you the picture of the apple tree, and I said, the goal was equity and the goal was justice, and I absolutely believe that, and I think that that justice piece is particularly important. But I also find it's really important to stop for a minute and remind us of this particular figure by the Robert Wood Johnson Foundation of the difference between equality and equity. Because whenever we start to talk about trying to address inequities and trying to fix inequities, I think we get very bogged down with the concept of fairness and making sure that everybody gets exactly the same thing. And that if you're going to try to help people, that you have to make sure that you help all people equally exactly the same. So many of our interventions have been focused more on equality than they have been around trying to achieve equity. And I just find that this particular infographic just describes this better than anywhere else that I've seen. We cannot be distracted by trying to be fair because each person or each population needs a particular intervention, may need a particular level of an intervention that's different. And if we spend our time making sure that everybody gets the same intervention, we will not be successful. Okay, so here are a couple of things that we can start to think about. One is, I think most important, is personal work, which is education and self-reflection. And that is, I think, the most fundamental step that one can take. And it's the thing that we have the most power over. And then after that, I think that we need to start as a group being better about promoting social norms of inclusion and equity and respect, and then advocating for racially equitable public policies and speaking up and taking a stand. So if we're going to talk about education and self-reflection, I have a number of resources. It is just the tip of the iceberg, but it's just a starting place for where we might start to think about things, about how to educate yourself on these topics. And so James Baldwin, again, because I love to quote James Baldwin, said that the purpose of education is to create in a person the ability to look at the world for himself, to make his own decisions. And I think that that is, we've spent too much time kind of being fed things that are not accurate, things that are not correct. And I think that we need to consume different information and then come to our own decisions. So here are a couple of resources that would allow us to consume information a little bit differently. Here are some books that I find to be particularly helpful around thinking about some of these concepts. As I mentioned before, The Protest Psychosis is the book that specifically focuses on schizophrenia. But the other books on this list, The New Jim Crow, Why Are All the Black Kids Sitting Together in the Cafeteria, and Fatal Invention, are much more kind of broader books thinking about race, thinking about racial identity development, thinking about the war on drugs and mass incarceration. And then I Am Not Your Negro is, I mentioned James Baldwin twice already, so this is my final James Baldwin reference, but I Am Not Your Negro is a documentary that describes his concept of racism in the United States in his own words, through his writings. So I think it's really a particularly good documentary for really kind of understanding the issues as it relates to racism in the United States. Here are a number of other books and podcasts in particular. The first one at the top there, Seeing White, is a really excellent documentary. It's a podcast documentary that has multiple episodes that really kind of defines the concept of whiteness and does so in a really effective way. So I highly recommend that one. NPR's Code Switch is just a much more kind of fun and engaging podcast. And the final podcast on this list is the 1619 Project. I think it's a really exceptional podcast all across the board, but there is a particular episode, I think it's episode 4, that focuses on healthcare. And that one is particularly good, especially as it relates to how healthcare how structural racism has kind of infected our healthcare system, and how the AMA was complicit in kind of keeping our healthcare system in this structurally racist manner. And then, of course, White Fragility and How to Be Anti-Racist are very popular books right now that are, I think, popular for a reason. They're very important books. They really help to introduce people to this topic. And then White Rage by Carol Anderson is another book that really highlights this. And then the other things that we have to do for ourselves, that I said, education and self-reflection. So we consume this information, we educate ourselves on this topic. And then we have to shift our mindset to not being about trying to achieve cultural competence as much as we need to think about a practice of cultural humility. And cultural humility is a concept by Melanie Turvalon and Jan-Marie Garcia, in which people commit to a lifelong process of self-evaluation and self-critique. And that is the fundamental first concept of cultural humility. And I think that part is so important. This is not something that we can put a couple of weeks into, a couple of months into, and then we're okay and we're done. This is a lifelong process in which we're constantly evaluating, reevaluating, we're constantly looking at ourselves. I find that this is work that I do almost every day. That I notice bias in myself, that I notice thoughts, I notice myself trending into cultural and biological determinism almost every day. So being able to identify it, being able to look at it, to evaluate it, and to critique it, to be able to really get to a place where, like, you hear these things in your head, and you don't necessarily, you're not kind of shocked by the guilt around having the feeling, as much as you are looking at and evaluating the feeling and making sure that you think differently the next time. Another part of cultural humility, which is really critical and relevant to how to change things, is this desire to fix power imbalances between providers and clients. And it says providers and clients, but I actually think it is a desire to fix power imbalances across the board. Because the reason that we have social injustice in the first has to do with a number of power imbalances in various settings and locales. So the idea is that we are trying to put those power imbalances right. Just a very quick example that is very relevant to mental health is this idea that we are really good. I think we've gotten very good as a field, particularly in psychiatry, of doing a suicide risk assessment. And so we often do these suicide risk assessments. We have all these risk factors that we look for, and we determine if somebody is high risk, if they're moderate risk, if they're low risk. But we don't always acknowledge that there is a massive power imbalance whenever someone is conducting a suicide risk assessment. Because what happens is that psychiatrists have the power to take people's rights away. Psychiatrists have the power to put people in institutions against their will. And if you have not acknowledged that power imbalance, to have an expectation that somebody would just kind of freely share information with you without acknowledging that power imbalance, I think really lacks an insight into how power works. And then finally, developing community partnerships to advocate within larger organizations in which we participate. And that, I think, speaks to itself. It's really about forming coalitions and working together. So as I mentioned, it's public policies and it's social norms, and that's what we are really driving towards, and that's what we're trying to accomplish. And so one of the things that we can do is promote social norms of inclusion, equity, and respect. And that includes thinking about the beauty and strength in diversity. And it can include enforcing social norms of inclusion and equity, meaning that when you see people that are not following those social norms, to kind of make sure that we have policies in place that are inclusive and equitable. Educating or legislating to change social norms. And what that really means is this concept or idea where sometimes people have wrong ideas about things. And again, I mentioned that I have these thoughts from time to time. We all have these thoughts. If we grew up in a society, we have negative social norms about certain populations from time to time. And much of the time, this can be addressed with education, with that work that we talked about doing. But sometimes you can educate forever and ever and ever, and people still don't come to a place of understanding. And in that case, that's when legislation comes into play. So legislating to change social norms is when you're taking action, when you're taking steps to remove people who are harmful from situations. So if you have someone who's kind of a constant offender, who has berated students consistently over the course of many, many years, the answer is not to try to do some sort of remediation or try to work with that person. It's really about removing that person from doing the harm that they're doing. And observe and challenge your own implicit biases, which we've already kind of talked about a little bit, and evaluate and break down unnecessary hierarchies. So that is that piece about power dynamics that I mentioned. And the question becomes, how many of the power hierarchies that we have in our society are there because they need to be there? Because I do think that there are times when hierarchies need to be in place. But how many of them are really just there so that we can feel that we have power over another group? And that they're unnecessary. So particularly in medicine, particularly in psychiatry and mental health and mental health and substance use disorders, I think we need to look at which of the hierarchies are necessary in order to function, and which of the hierarchies we need to eliminate because they're really not there serving any sort of purpose. And then the piece about advocating for racially equitable public policies, that is this idea that all policies are health policies. And so that's when we are trying to move beyond the clinics, the hospitals, and the treatment centers to advocate for policies that address social determinants of mental health. This requires us to become political. It requires us to communicate with our elected officials and to promote equitable representation. And it requires us to form cross-sector collaborations and community coalitions. And finally, the last thing that we can all do is speak up and take a stand. And so I'll use these words from John Lewis. If you see something that's not right, not fair, not just, you have a moral obligation to do something about it. And so, you know, I've been talking for a while, and it sounds inherently political. And the reason is because it is. Political stances and policy interventions are required. Actually, you know, in psychiatry, we're taught to be neutral. We're taught not to intervene, not to take any sort of stated opinion on something. But to remain apolitical or neutral is in fact a political stance. It is the tacit acceptance of the status quo. And so unfortunately, we don't have an option. There's no option of neutrality. There's no option of being apolitical in this sense. And so the last concept I'm going to bring up before we open it up for discussion is this idea of progress, which is made through the passage of legislation, court rulings, and other formal mechanisms that aim to promote racial equality. And I think that we've made a lot of progress over the years in this space. We've made a lot of progress in mental health. We should be very, I think, reasonably happy with the progress that we're making in this place. But I think that as we start to think about progress, we also need to think about this concept of retrenchment. And retrenchment refers to the ways in which progress is very often challenged, neutralized, or undermined in key policy arenas. And so if you are not ready for retrenchment when progress is made, you can be blindsided. And retrenchment, you know, we're living in a time right now of great retrenchment. We're living in a time where progress that was made has led to us moving backwards in a very significant way. And not being prepared for that can be very debilitating as we're trying to do this long work over a lifetime. And so I will leave you with this quote by Elie Wiesel. We must take sides. Neutrality helps the oppressor, never the victim. Silence encourages the tormentor, never the tormented. Sometimes we must interfere. When human lives are endangered, when human dignity is in jeopardy, national borders and sensitivities become irrelevant. Wherever men and women are persecuted because of their race, religion, or political views, that place must at that moment become the center of the universe. And with that, I think we can open up the discussion for discussion.
Great. Thank you so much, Ruth. This was an amazing tour de force about these concepts, and I learned so much, and it was activating for me, which is great. It was activated in a way of activating my anger, my intention to do something. And thank you so much for bringing that to all of us. So there's been an active and lively discussion going on in the chat during your presentation. So I want to encourage people who have specific questions to go ahead and put those in the chat, and then I'll call on you. In terms of some of the things that have already been mentioned, I wondered if there was a question about stigma and some discussion about that. So you mentioned that as sort of an excuse that sometimes is made in terms of why there are inequities in mental health. But can you talk a little bit more about whether, you know, what is the interaction between stigma and culture, and what role does it have, and how can we address that stigma?
Yeah, thank you. That's a great question. And so, you know, I certainly didn't want to imply that stigma doesn't exist, because it clearly does. But one of the ways I want to think about it when we talk about different cultures is that we often, again, revert to a cultural imperialistic view of stigma. We say that, and I've heard everybody say this before, you know, like Black people have more stigma about mental health than other groups. I actually don't think that levels of stigma are actually that significantly different across populations. I think that all groups have stigma towards mental illness. Mental illness and substance use disorders are, again, a population, a group that is oppressed and marginalized. And so as a result, people have stigma associated with being identified as part of that group. But I don't particularly think that the group, certain groups or certain cultures are just worse. That perspective really kind of implies, again, that kind of white dominant culture is normal, and that their level of stigma is kind of the normal level of stigma. And then everybody else's level of stigma outside of that is the abnormal level of stigma. So it's really about kind of changing the frame. And I will also just add one other concept related to this, which is, we didn't talk about this today, but it's really critical that we understand that there is a lot of really good data about discrimination and how much people experience discrimination in accessing healthcare. And particularly, I'm thinking about how much discrimination people experience in accessing mental health services. And most importantly, when they access hospitalization and inpatient mental health services, but all mental health services. And so we have these high rates of discrimination and access to care. And you see those high rates across the board for different populations, for Black and Latinx and Indigenous populations. So my question is, for anybody who's ever experienced discrimination, how urgently or how quickly did you want to return to that place that you were discriminated against at? And I bring that up because, I myself have been at restaurants before where I've been discriminated against, and I just never go back to those restaurants. And so I think that, Black, Latinx, and Indigenous populations maybe have encounters with the healthcare system in which they're discriminated against. And after that, they make a determination that they'll do whatever they can not to have that experience again. They will avoid that. And it's not necessarily stigma driving that as much as it is discrimination. So the stigma is not necessarily, oh, mental health is bad and we don't, as a culture, we don't believe in mental health problems, as much as it is the system has not served us well. And when we have tried to receive help for these conditions, we have not been treated in an equitable manner. So I actually think that's the bigger driver rather than stigma. Again, stigma is important, but I just don't think that it's everything.
Great. Annie, do you want to unmute? And you sort of raised an issue about representation. I wondered if you wanted Dr. Shim to comment on that.
Yeah, and I mean, this is from my own experiences, just remembering having to translate for my mother and my aunts, and just that level of both stigma and distrust with the healthcare system, and how whenever there was a health provider that was a person of color, my mother and my aunts would feel a bit more comfortable, or if it was someone who would speak the language, they felt more comfortable. So I feel that the representation from my own personal experiences do matter a lot. And that's one way that we could actually, by fixing the pipeline, we could navigate those conversations a lot easier, giving that these patients may actually feel more comfortable disclosing mental health problems. There's times too that there's a cultural difference in the way that these mental health issues are expressed. And there's many times that patients actually don't realize that they have depression or they're experiencing substance use disorder unless, the healthcare provider is able to recognize those symptoms.
Yeah, thank you for sharing that. I totally agree. And I think the pipeline is really critical. And I keep beating this drum, but there is a very specific reason why the pipeline is broken. And the reason that the pipeline is broken is because of structurally racist policies that were put into place at the beginning of the creation of academic medical centers. So, the Flexner report, I can't remember the year, I'm bad with years, but I think it was, I don't remember, 1907 or something. I don't remember when the Flexner report came out, but that Flexner report was responsible for increasing the research rigor of medical schools, but also led to the closure of 5 of the 7 historically Black medical schools that were operating in the country. And it led to the closure of the 2 women's medical schools that were in existence at that time. And so it was not like those women or those people of color or those Black people could go to other medical schools. They were not allowed to go to those other medical schools. So the shutting down and the excluding people from attending medical school has been actually in place from kind of the beginning of medical education, and it has extended to where we are today, where we're still seeing efforts to prevent certain populations from getting into health professions educations, from being successful in that place. And it starts with kind of the structural racism within the education system, and then extends all the way to that. So it ends up being one of these things where you can see these problems almost, once you start to notice the problems, you see it everywhere. And it can be a little bit discouraging because there's so much work to do, and you have to just kind of work within the space that you are capable of working in.
Thanks. Brett Johnson, did you want to pose your question about intersectionality?
Hi there. Sorry, I'm having some technical difficulties here, but I was just wondering if you could touch on the how intersectionality is involved here, because I know so many of my female people of color who are in academic settings who describe being marginalized not only as a female but as a person of color as well. And also how that plays out in healthcare discrimination as well.
Yeah, thanks for that question. I normally have a slide on intersectionality that I cut for time. So I'm sorry I didn't get to talk about that in greater length, but you're absolutely right. Intersectionality is a huge piece here. And I also think it relates to the concept of cultural determinism and biological determinism, because again, when we think about these groups, we try to neatly categorize people into like one group. And most people are not one thing. Most people are many, many things. In fact, all people are many, many things, right? So this idea that we can distill somebody down to one aspect of their identity when multiple aspects of their identity are always at play is a fallacy. And who are we to say which aspect of which person's identity is the most significant to them? And the most significant to their experience? And why does there have to be one that is most significant? Why can't it be that these multiple intersecting identities all create you to be that one person that you are, that is, you know, that person? So all of those things come into play. And I would just say again, particularly when we talk about mental health and substance use disorders, that same intersectionality becomes much more pronounced, because what you do see, oftentimes when we talk about intersectionality, you're seeing kind of a collection of oppressed groups. You're seeing that outcomes become worse for people who have multiple oppressed identities or multiple intersecting identities that are marginalized or oppressed. And I think the perfect example of this is actually thinking of Black trans women of color. Black trans women. Because Black trans women have the highest rates of murder of any other population, of any other group in this country, have almost epidemic murder rates. They're victims of violence, which, as we said, is a form of oppression, at a higher rate than any other population. And I think that the reason that they are so commonly victims of violence has to do with the fact that their oppressed identities happen to be at this intersection of some of the most oppressed groups. And so you bring those oppressed groups together into that population, and they are at extremely high risk. And then what you see is that we don't, in fact, always create policies to protect that particular population because we've deemed that population not to be as important as another population. So you see this kind of how oppression and intersectionality comes together to create harm. And then you see how our response may not always be trying to protect those groups or appropriately pass laws to protect those groups.
Great. We also had a question from Susan Powell. Susan, you want to unmute?
Sure. Yeah. Thank you for an excellent talk today. I really enjoyed it. I was wondering if you had any recommendations for any programs that have been incorporated into medical education to address some of these issues.
There's a lot of programs actually happening across the country. There are social curricula that are starting to pop up in various places. I'm actually not as familiar with the medical student education social justice curriculum, but they do exist. I'm much more familiar with the fact that many psychiatry residency programs are like leading this charge. And what's great about this is that the psychiatry residency programs that have done this work really well, oftentimes it's been resident led. So residents are kind of creating the curriculum, implementing the curriculum. I just actually, it's probably illegal for me to say this, but I just reviewed an article describing 3 different social justice curricula in residency, in psychiatry residency programs across the country that are being implemented. And it's very exciting. So you know, Yale is probably the program that has the most publicity around their social justice program and their social justice education. But I'm quite aware that other programs here in California, I think at Davis we've kind of threaded some of that into the curriculum, but it's not kind of a formal program. And I think it's the same at UCLA. And I think there are a couple of programs I think that, I'm trying to think of the other programs. So again, Yale is probably the most popular one. The programs that I think are kind of up and coming in this are relate to Howard and UCLA as well.
Great, and that's actually a great segue to our next question asker, who is Eric Raffalo-Yuan. So Eric, do you want to ask your question? And also I'll give you a time to advertise some things that our residents are doing for people.
Yes, thank you, Dr. Shim, for your talk. So my question, and maybe very specifically, so you're coming from UC and we're all also at a UC, and for the most part. What are things that an academic UC psychiatry department can do both internally and externally to make progress on this issue?
Oh, that's a huge question. Well, so, you know, I actually think that the best way to move forward on this from a department standpoint starts with leadership. So leadership, I think, has to fully comprehend these concepts and be committed to working on them. I feel like if you don't have that, the work is kind of, it's possible to do the work, but it's much harder. So I think that that's step one, is leadership that's not only committed, but also willing to commit support, financial and administrative and moral and personal support to those efforts. So that's step one. And then I think the step two is back to those recommendations of forming coalitions. I think that maybe, you know, I know you guys have a committee that works on issues as it relates to diversity and equity and inclusion, but maybe there needs to be a specific task force that's about like dismantling structural racism and coming up with maybe some actionable 1 or 2 or 3 strategies that you can work on as a group. That work, I think, can be most successful when it is directly in partnership with the community. So engaging the community from the very beginning and having them be equal partners rather than kind of, used only for their needs. I think those are probably the best starting points, and then the work kind of flows out of the energetic people that want to see a change.
All right, thank you. Yeah, I especially appreciate your comment about how important it is for leadership to be invested in the change.
Thank you.
The other two things, so I wanted to thank the psychology and psychiatry trainees who made this talk possible, so big thanks to them. And then a couple of upcoming events for the psychiatry resident rounds. I just wanted to give some quick details. So Dr. Lekha from UCLA is going to be presenting on psychiatry and slavery on October 15th from 8 to 9:30 a.m. And then on October 29th, Dr. Fu, who is the chair of ethnic studies at the University of San Diego, is going to be doing a 13th documentary viewing and screening. And so some details on these will be sent out as well.
Great. I wanted to let people know before we go to some of our final questions in this main session that if you are a trainee in our department, you are welcome to join us for the trainee discussion hour that's going to happen after this. And so if you are if you want to do that, then you'll just need to stay on this Zoom after all of us non-trainees leave, and that'll be a space for more questions about for Dr. Shim there. I wanted to now go to Emma Troyer. Emma, do you want to unmute and ask your question?
Yeah, hi, thank you, Dr. Shim. I just wanted to ask you, I thought it was interesting that you mentioned a colleague in California wasn't able to believe that medical students would be as biased in California as they would be in the South. And I grew up and moved from the Midwest to California. And so I was wondering, do you find this type of thinking to be common in progressive states like California? And in academia in California, how do we combat this sort of exceptionalism? Like, we have arrived in becoming progressive and equitable.
Thanks for that question. It's one of my favorite things to talk about, because it's really interesting how we often like to say we like to group ourselves into categories, and we like to say, oh, we're progressive. And yet we can do a lot of damage that way. So actually, I think that we lull ourselves into a false consciousness or a false belief that we don't have these problems, when in fact that we do. I love the question, but I will just tell you, I mentioned that Seeing White podcast. And there's an actual whole podcast episode on this exact concept. The idea that certain parts of the country like to look at other parts of the country, and how we consistently look at the South kind of like as a punching bag, right? And we always say, oh, those people in the South, like if we could just get over them and their backward thinking, we would be fine. When actually that's not the problem. And that's also just like not a nuanced way of looking at how the South is. And how it leads to us kind of allowing ourselves to feel better about ourselves, but also overly simplifying things and falling again into traps of cultural determinism. So I think it's actually really critical that we rid ourselves of the assumption that we are doing things right, because there's just unfortunately nowhere, I'm not aware of anywhere in the country, anywhere that's doing this properly. And I think that it can be even more damaging. I've talked to my friends on the East Coast. It can be even more damaging to be in places like California that kind of sometimes think that they're doing good work around this space when they're not. So there's a lot of work to be done. I very much appreciate your question.
Thank you.
All right, one last question in this main session from Kristen Jezier.
Thank you so much, Dr. Shim. So I was just hoping to get a sense if you know of any best practices or articles that talk about how to support and set policies around clinicians, all the way from externs to faculty who are victims of racism or othering or microaggressions, those sorts of things that happen in clinical interactions. You know, back when I was a trainee, I remember experiencing some of these things as well as for my peers. And of course, these things still occur now. The last time I did a lit search, maybe, I don't know, a month or two ago, there's still a lot of opinion pieces and some articles out there, but I haven't found any like real solid best practices. So I was just curious if you have any resources or thoughts around that. I'm sure it's still an area for growth and improvement.
Yeah, thank you for that question. And you're right, it is a major area for growth and improvement. So I'm not aware of a lot on this topic, but my colleague here at UC Davis, Kapiri Ackerman Barger, who's a nurse, she works with a group that includes Darren Lattimore at Yale and Doan Boatwright at, I can't remember where he's at, maybe Yale as well. But they all work together to, so it's been dangerous actually to study this topic. The reason that we don't have data is because nobody wants to capture data at their institution about microaggressions. It may be the reason that Dr. Eiler and I were not successful. Eiler and I were not successful in our attempts to get funding to look at this issue, because nobody wants to say, look at my school, look at my institution, and look at how badly we are microaggressing against people. And so it is, I think that's why that data that came out of UVA about medical students' beliefs about Black people having, you know, nerve ending differences and skin differences was so kind of shocking, because that's really harmful data for the reputation of UVA. And other schools have squashed that type of data from coming forward because nobody wants to be known as the school that's the racist school or the school that has all the microaggressions. So my colleague, Dr. Ackerman Barger, and her colleagues have done this great work in which they've pooled all of their data so as not to identify like one program or one particular school. And I think that's been effective, and they've published a number of papers in this space. So I would look specifically for Boatwright, Lattimore, and Ackerman Barger for specific studies on data around microaggressions. Now, that being said, they didn't necessarily make a bunch of policy interpretations about what must be done. But I will tell you, and I will agree with you, that there's not a lot of data on this. There's not a lot of policy or like what to do. There's not a lot of interventions that are kind of loudly stated. But I did find one out there in the midst of all, and it was not a study. It was nothing published, but the Mayo Clinic put out a document in which they described how they deal with microaggressions, particularly coming from patients, and like how as an institution they address microaggressions as a culture. And I actually thought that was a very well done document. I thought it kind of was a policy that they wanted to enact across their institution to say, you know, this is not tolerated at this particular institution, and kind of give people a very clear script as to how to address those things. So it's just kind of the tip of the iceberg, and it only covers one very, very minor type of interaction as it relates to microaggressions. And I think the rest is exactly as you said, there's a dearth of literature and there's not a lot out there.
Thank you.
Great, thank you so much. Well, this has just been amazing. I really appreciate your work here in this area, Dr. Shim, as well as all the great questions that we have. I wanted to thank you on the behalf of the department. And Sean, can we get a visual here? We have a tradition for our speakers at the department that we give them a little token of our appreciation for coming here. And hopefully Sean's going to get the picture up soon so you can see what's coming. But basically, it's a UC San Diego hat with the Department of Psychiatry on the back. You might be careful where you wear it around UC Davis and making sure you're not offending anyone. There we go. But we hope that you will wear it with pride, and we really appreciate you having become temporarily a member of our family today and helping us out. So again, thank you so much for all that you've done and will continue to do. And for the trainees who are interested in meeting with Dr. Shim after this, please stay on the line. Everybody else, please clear off to make room for that, and have a wonderful day.
Thank you for the hat. I'm so excited.